So, Doctor, I was so fascinated by the fact that we now have serological or antibody tests here in Rhode Island, but I understand there is a process that has to take place before we can start administering them to the general public. So I was hoping first you could just sort of walk me through what that validation process looks like.
Sure. There's a lot of interest in doing antibody testing right now. And so just to explain, antibody testing doesn't directly detect the virus. That's what we use our PCR testing for. This detects the presence of antibody and tells you that you've had exposure to the virus or been infected with the virus in the past. And it usually takes about 2 weeks to develop antibodies. And so there's a lot of interest in these tests because we need to begin to get an understanding of just how many people in the state of Rhode Island have been infected. And antibody testing is a good way to do that. But what you have to be careful about with antibody testing is that the test is accurate. And so if you don't know the performance characteristics of the test well, and the test has problems with false positive results or trouble with specificity, which a lot of antibody tests have, you're going to get a lot of false positive results, and it's going to look like more people are infected than actually have been infected. And it's going to be misleading information and make it difficult for people at the Department of Health and the governor to make decisions about releasing people from social distancing when they don't have an accurate understanding of the number of people that have been infected.
So what is your role? I understand you're sort of leading a team of people, correct, who are going to drill down into how accurate this test is. And can you just sort of walk me through, I know you have to have control samples and samples that you know are infected. So how does that all work, and how long is this process going to take?
So Dr. Jake Curtis and I are co-chairing this task force together. And one of the first things we're going to do is design a validation study for serology. So what you need to do is test people that you know don't have COVID. And the best way to do that is to go into the freezers in the clinical laboratory and take out specimens that were collected on patients before COVID even started. So back in the fall, last summer, when COVID wasn't circulating, so you know those patients couldn't have been infected with the virus. So those will be your negative controls. Then the Department of Health has a listing of everyone who's tested positive for COVID. So you can test a group of those patients, and those are people that should have a positive test for COVID antibody. And so those two populations together help you determine what the performance characteristics of an assay are.
How many samples do you expect to test and over what period of time?
So to do a good specificity study, which is to ensure that there aren't a lot of false positives, you need a large number of samples. We're probably going to have to test 1,000 patients that were not exposed to the virus, that we know definitively have not been exposed to the virus.
And is there enough blood in the freezers to do that?
That's what we're going to be in the process of finding out. But between Lifespan Laboratories, Eastside Clinical Laboratories, hopefully we will be able to come up with enough samples to do that sort of testing.
And obviously there are plenty of COVID positive patients here. So are you going to be looking at people who were recently infected and also people who you know were diagnosed quite some time ago?
They all should have antibody. So it takes about 2 weeks to develop antibody. So anybody who's a good 2 weeks out from their initial infection, they should have antibody in their blood.
So how long do you think it will take? Will it take a couple of weeks to finish this validation process?
Probably. By the time we get it organized, find all the specimens and do all the testing. And what we're hoping to do is get a bank of specimens that we can use on more than one test. So as every day I hear about a new serology test that's been made available for commercial use. And so if we can identify a bank of specimens and have a large enough volume of them that we can test a variety of different assays to determine which ones perform the best.
Oh, okay. That's interesting because I believe we had asked at one of the press conferences which test the state had purchased, and it was the SD biosensor, but you're going to be testing other ones as well?
We may be able to test other ones as they become available, but you're correct. The state has the SD biosensor test.
And I was doing a little bit of research. I'm not a medical professional by any means, but I was doing a little bit of research last night on the SD biosensor test and in terms of the percent of specificity and all of that. And I'm just wondering, from what you've seen in the publications you've been reading and sort of what the company has disclosed themselves, do you have any concern about how accurate this particular test is?
So that's a really good question. And the reality is there's very little data out there. The company's data had, I think, 35 or so positive specimens and 30 negative specimens. So it's a very small sample, and it's not a large enough sample to give you a good understanding of how the test performs. So, and there aren't any peer-reviewed published literature on these tests yet. So that's why we have to do such a large study ourselves. If there were more data out there and more published data out there, we could use those and make this process a lot easier for ourselves.
So you're really sort of learning as you go here. What you're doing is important, not just for Rhode Island, but probably for lots of other places as well.
Yes, I think we're all in the process of doing these types of studies to see which of these tests really rise to the top and has the most accurate performance.
So after this multiple week period where you do this validation, what happens from there? Do you sort of say, okay, here's what our findings are? Can you say, we don't feel comfortable using this test? Can you just sort of walk me through what happens when you're done?
It's possible that we'll say this test doesn't have a high enough specificity that we don't think that we can use it. Hopefully that won't be the situation, and we will be able to deploy the test and out in the community. Parallel to what we're doing, another group is putting together a seroprevalence study. So determining how many in the population need to be tested, how to get a good random sampling of people in the state of Rhode Island. So those two projects will be going on in parallel. So once we identify that the test is reliable, then they can deploy it and start testing people across the state. Because that's a logistical challenge itself also.
Yeah, that was going to be one of my next questions. How do you know if you truly have a random sample? But it sounds like that answer is in progress.
Right, and biostatisticians over at the School of Public Health are helping people at the Department of Health determine the best way to do that sampling.
One of the big questions we've been getting from viewers is, if I get COVID-19, am I then immune? And I know that is $1 million question that you guys are going to be looking at throughout this study. So can you just sort of walk people through what this will eventually hopefully tell us about immunity and antibodies and all of that good stuff?
You're right, that is the $1 million question. And for some infections, antibody protects you from getting infected again. We do not know if this is the case for COVID. We do not know that if you have antibody, that you then won't get the infection again. And so people have to be very careful if they do get antibody tested and they find out that they are positive for the antibody. That doesn't mean that they're immune from getting infected again. It doesn't mean even if you are shortly out from your infection, it doesn't mean you can't pass it on to somebody else, even though you're starting to feel better and you have antibody. We just do not have the answers to those questions yet. They're very important questions that need to be answered. But until we do, whether you have antibody or whether you don't have antibody, you need to abide by the social distancing rules that are in place, wear your mask, you should behave in the same way that someone who hasn't tested positive for the antibody would behave, particularly if the test doesn't have a high specificity. We know we're going to get some false positive results. You really cannot make decisions on that it's safe for you to be exposed to people just because you have a positive antibody test.
Can you just walk me through, doctor, how this test is administered? Is it the pinprick on your finger?
You can do a pinprick on your finger, or you can draw blood and use the serum or plasma from a blood draw. We will probably be testing it on serum or plasma because the hospital labs and the reference labs in the state do not have pinprick samples that we could use to validate the test. And whatever sample you use to validate the assay is the same sample that you need to use when you actually perform the testing.
That makes a lot of sense. So that sort of brings me to my next question. Do you know what the plan is then If you say, great, let's do this test, it gets the green light, what is the plan for rolling it out to the general public? I know the swab testing that's being done to test for COVID is a drive-up situation at a tent most of the time. Do you foresee a similar system being implemented for antibody testing?
That's a good question. If we end up using a blood draw, then you're going to have this testing drawn either in people's homes or at draw stations, like when you go have your blood drawn prior to seeing your physician in a hospital-based lab or out in a draw station out in the community. So depending on what test we use, what sample we end up using, that will drive decisions on exactly how this will be deployed out in the community.
Do you think that will make it a little bit more difficult? I know in some places they've been doing these pinprick tests in the supermarket to try and access a randomized sample of people. Do you think because it will be a little bit more of a cumbersome process that it might be harder to get that random sample?
We have to draw blood and use serum. Yes, it does make it more challenging. There are collection devices that are available that they have used in resource limited environments and in resource limited countries, where you can draw into, I was just talking to Dr. Curtis about this yesterday, where you can draw blood from a finger stick and still collect the serum or plasma from that. So there may be devices out there that we have used out in the field in other countries that we might be able to apply here.
Fascinating. One of the things that caught my eyes, I was doing some research last night, is that other local places, clinics are already offering antibody testing. What can you say about the clinics who are offering this testing, and how is it different from what you guys are doing?
I don't know what tests people are using. The big question everybody should be asking is, can I please see your validation data so I know the sensitivity and specificity of that test?
And what should they be looking for if they do ask for that data and are presented with it?
You know, you need a very high specificity. Ideally, you would like a specificity that's 98, 99%. And the same with sensitivity. You know, I don't know that these tests will hit that mark. A lot of tests that we use out there don't necessarily hit that really high sensitivity and specificity. But we're trying to find the better of the tests of the ones that are available.
Gotcha. And do you know how many of the tests you'd ideally be able to validate or try to validate?
I would think that we could probably do a handful of different tests. There's probably a dozen, 20 or more serology tests that are out there now. We will not have the resources to do all of those tests. And hopefully we wouldn't have to go through that many tests before we found one that had a good performance characteristics.
I know down at Westerly Hospital, they're trying the experimental convalescent plasma treatment. Do you think that this will open up a pathway to be able to do that more broadly?
It is a way of determining who has antibody after acquiring the infection. What it doesn't tell you is what the titer of the antibody is, and that is probably going to be important when you talk about using the convalescent serum or plasma and how effective that's going to be. So a lot of those studies are underway right now on a national level to determine what is the amount of antibody that's in a given person's plasma and how much antibody do you need to actually protect somebody or to reduce the severity of their disease if you give them the plasma.
Just sort of on a personal level, is it cool to be sort of on the cutting edge of an epidemic like this, of testing like this as a medical professional? How does it feel to know that you're getting up, going to work, and doing some stuff that could have repercussions nationally, globally, and for many years to come?
So that's an interesting question. I think this social distancing has been very challenging for people. And I was talking to some colleagues the other day, talking about how it's in many ways easier for us to get up and go to work, even though some people might look at that as stressful, but we're very much engaged in what's going on and doing what we can to care for patients, to make decisions on testing. So it's always really exciting to be an infectious disease physician, I must confess. But these days it's very interesting, and there's a lot that we can do to drive our understanding of this virus forward.